Assalamu alaikum. It's my great pleasure to introduce my dear colleague and my dear friend, Professor Lobna Eltouny, the head of the endocrinology and diabetes unit in Astute University. Professor Lobna is going to speak about the recent updates in type 2 management, type 2 diabetes management, and the composite group. تفضلي دكتورة.
Bismillah ar-Rahman ar-Rahim. I'd like to thank Professor Ines and all the Arab Association for the Study of Diabetes and Metabolism group for this mega conference, sharing with a multinational speaker from all over the world. And also I would like to thank MSD to give me the chance of their symposium, which is talking about the composite program, speaking about the recent update in type 2 diabetes management. Overview في three composite studies, one dealing with the comparison of the up titration of metformin plus sitagliptin versus metformin up titration alone, and this is the composite M. ودي غالبا بتكون في الستارتنج البيشنتس اللي هم بيكونوا في early diagnosis of type 2 diabetes. Another study which is called the composite R, comparing the using sitagliptin versus dapagliflozin as one of the SGLT2 inhibitor in diabetic patients with mild renal impairment. And the third one which occur in the advanced stage of diabetes when they add the basal insulin, whether we continue the use of oral as sitagliptin or discontinue it, and it is called composite I. الستادي الأولانية اللي هي بتقارن إلى composite M بتشوف clinical efficacy and safety of sitagliptin in patients with inadequately controlled on submaximal dose of metformin alone. الستادي ديت كانت بتشوف إن البيشنت لما تايب 2 diabetes وانكنترولد على الميتفورمين 1 جرام هتبقى حاجه من اتنين، اما ان انا اعمل اب تايتريشن للميتفورمين لغايه ما اوصل للماكسيمم دوز، او ان انا اضيف another oral anti-diabetic therapy with another mechanism, complementary mechanism of action as sitagliptin, one of the DPP-4 inhibitors. والستادي دي كانت its duration about 20 weeks. دي البيزلاين characteristics of the patients when we add sitagliptin under covering of metformin versus up titration of metformin to reaching the maximal dose. At the end of the study, which is about 20 weeks, we look at this curve, which shows that in patients adding sitagliptin to metformin, there is greater reduction of A1C at week 20 with sitagliptin versus placebo, and it means only metformin alone with maximum dose, which is 2 grams. Also, there is no increase in the body weight in both groups. And احنا عارفين طبعا السيتاجليبتين والميتفورمين, there is no increase in the body weight according to their mechanism of action, and they are considered to be a neutral regarding the body weight in diabetic patients, which most of them showing overweight or obesity. Also, there is the adverse events. There is no difference between both groups regarding adverse events, even in the episodes of documented symptomatic hypoglycemia, which is very common, which is one of the common side effects we fear of it. But in sitagliptin, we know it acts through stimulating insulin in a glucose-dependent manner. So it is one of the drugs that didn't cause hypoglycemia together also with metformin. يبقى السمري بتاع الكومبوزيت ام ان البيشنتس with type 2 with inadequately glucose controlled on submaximal dose of metformin بيبقى حاجه من اتنين، اما ان انا اعمل اب تايتريشن للميتفورمين لغايه ما اوصل للماكسيمم دوز، او ان انا بضيف early initiation of sitagliptin. لما اضفنا الايرلي انيشيشن اوف sitagliptin مع الميتفورمين ماكسيمم up to 2 جرام versus metformin alone, this provides greater reduction in the A1C, no increase in the body weight and comparable safety and tolerability profile. لأن أنا بستخدم 2 drugs with 2 mechanism of action, complementary mechanism of action، فأنا متوقعة إن هو هيجيت benefit في ال A1C من غير ما يعمل لي adverse effects للدراج ومن غير ما يزود لي البادي ويت. يبقى دي الحاجة اللي احنا بنلجأ لها. ودلوقتي بقى في initiation, early initiation of combination therapy versus starting monotherapy and up titrate it in the management of type 2 diabetes. And usually the patient بتوع type 2 diabetes بنبتدي ب stepwise care fashion, but this is delay the goal of reaching the A1C, and so it is better to start initial combination therapy in the management of type 2 diabetes. This place, I hope next year all the multinational visitors will see these areas in Aswan and in Luxor. The another study is addition of sitagliptin or dapagliflozin in patients with type 2 and mild renal impairment, which is called composite R study. في الستادي دي غالبا second line therapy or third triple therapy, because in this study they use the metformin on 1.5 gram with or without another drug which is sulfonylurea. So it is a triple therapy in some degree of advanced stage of diabetes. We add dual and triple therapy. The second line therapy after metformin or the triple therapy, usually there is competition between these two groups, either SGLT2 inhibitors or DPP-4 inhibitor. In this study, they compare adding sitagliptin 100 gram versus dapagliflozin, one of the SGLT2 inhibitor, on a background of dual therapy of metformin plus minus sulfonylurea. This is the selected baseline characteristics, and usually we see the duration of the diabetes usually increase when we use triple therapy, and the A1C is uncontrolled. At this study, most of the patients received the full 10 milligram dosage of dapagliflozin as shown in this slide. And at the end of the study, which is about 24 weeks, there is a greater reduction of the A1C in the group using sitagliptin versus the dapagliflozin at the end of this study on a background of metformin and or sulfonylurea. Also, there is greater proportion of cases reaching the goal of A1C less than 7% at the end of the study in the group of sitagliptin versus the dapagliflozin. Actually, we know in patients with impaired or mild renal impairment, we know that sitagliptin we can use even in the moderate or advanced stage. But in this case, usually patient with moderate, which means that the eGFR between 90 and 60. And we know that dapagliflozin in moderate and advanced stage of renal affection, there is contraindication of using it in advanced stage. However, in sitagliptin, they use it even in dialysis. But in this case, in this study, they use it in mild renal impairment, and they show the greater about doubling the dose, doubling the number of participants reaching the goal of A1C. Actually, because of the mechanism of action of SGLT2, we know that this drug induces weight reduction through the diuresis and through the osmotic, through glucosuria and its effect on the fat. So there is a reduction in the weight in the group using the dapagliflozin. Furthermore, there is a reduction in the systolic blood pressure due to the mechanism of action of this drug. Regarding the overall adverse event, there is no difference between both drugs regarding the overall adverse events and whether hypoglycemia, as we know both drugs didn't cause hypoglycemia. And if it is occurred, usually due to the addition of sulfonylurea or the background of sulfonylurea in patients using these medications. However, in the dapagliflozin, as we know, because it induces glucosuria, so the prevalence of genital and mycotic infection are higher in the dapagliflozin versus sitagliptin, particularly in female diabetic patients. So the summary of the composite R: in participants with type 2 diabetes and mild renal impairment, these patients usually constitute about 40% of diabetic patients. with inadequate glycemic control on diet plus exercise and metformin alone or in combination with sulfonylurea, this means that it's a triple therapy. The third medication, either sitagliptin versus dapagliflozin, showed that treatment with sitagliptin at the end of the study resulted in greater reduction of the A1C relative to those with dapa or maximal dose, which is 10 milligram. Also, treatment with the sitagliptin and treatment with dapagliflozin at the end are generally well tolerated, with increasing the prevalence of genital amycotic infection in the dapa group. This is Aswan. It's a lovely Nile here. I hope all of the visitors will see it, inshallah, next year in physical conferences. The third study is the continuation at the long term, with increasing the long term of diabetes, and we didn't reach to the target. We add insulin, usually basal insulin, to the oral. So the question is whether we continue this oral or stop it. So the continuation of sitagliptin in patients initiated with insulin therapy in this study, what is called composite I study. In this study, we see the efficacy and safety of continuing sitagliptin versus discontinuing it in subject with type 2 diabetes using a background of or initiation of glargine due to the uncontrolling dual or triple therapy. We add the basal insulin for intensification and reaching the goal in such patients. The selective baseline characteristics, whether the patient continues sitagliptin, and this is the placebo one without sitagliptin. Usually the glargine, the basal insulin, the initiation of basal insulin started with 10 units daily, and we up-titrate or intensification of the basal insulin according to the fasting plasma glucose. If it is more than 100, we add 2 units, and if it is more than 1/4, we increase 4 units to the 10 units, and if it's less than 70, we reduce the insulin dose by 4 units. And usually the goal of the fasting plasma glucose, usually using the basal insulin single injection in the evening, and we controlling the fasting glucose, usually the goal is about 72 to 100 milligrams. Usually when we start the basal insulin, usually there is clinical inertia in intensification of this insulin, because most of the physician and the patient also fear of hypoglycemia when we increasing the dose of basal insulin. So if this can be a solution for this with continuation of sitagliptin, we'll see it in the study. This is the baseline demographic and anthropometric study and basal characteristic of the patient when they continue sitagliptin without, and those without sitagliptin on a baseline of basal insulin. At the end of the 30 week, we found that the group using sitagliptin, there is a reduction in the A1C significantly versus those without sitagliptin. And also the insulin dosage and those using sitagliptin is less than that in those without sitagliptin, and there is a change, a better change in fasting plasma glucose in those using sitagliptin. As we know, sitagliptin stimulates the endogenous GLP-1 and GIP, so they can stimulating insulin and stimulating and reducing the glucagon. This is the percentage of the cases that reaching the goal with A1C less than 7. It's higher in those with sitagliptin versus the placebo group. Also, the documented symptomatic hypoglycemia, because as we said, we fear of adding insulin or increasing or intensification of insulin because you are fear of hypos. So with the presence of sitagliptin, this usually stimulate the using the counter-regulatory hormone glucagon, so they compensate the hypoglycemia that may be induced with increasing or incrementing the dose of basal insulin. And this is appear in this study where the documented symptomatic hypoglycemia and the event rate are significantly lower in those continuing using sitagliptin on a background of basal insulin. So, in the summary of the composite I, after 30 weeks in participants with type 2 diabetes and inadequately controlled on metformin and sitagliptin, when initiating and intensifying titration of basal insulin, continue please the sitagliptin because this continuation versus discontinuation results in greater reduction in the baseline A1C and fasting plasma glucose, greater participant of reaching the goal with A1C less than 7, lower decreasing the dose of insulin, and this is beneficial because we know that in type 2 diabetes, most of our patients are obese, and if we increase the dose, we fear of both hypoglycemia and weight gain. So with the presence or with continuation of sitagliptin, it will reducing the daily dose of insulin and the similar overall tolerability and event rate, particularly the incidence and event rate of hypoglycemia. So in these 3 studies, the study of composite M, which use metformin, we initiate or we advise to initiate a combination versus up titration of the monotherapy because 2 drugs has 2 complementary mechanisms of action and results in reduction in A1C and reaching the goal. In the mid stage of diabetes, with when we add the triple therapy, either adding sitagliptin versus SGLT2 inhibitor, there is, according to the composite I, we found composite R, we found that there is a greater reduction of the A1C with a greater A1C goal of less than 7 in the Sita group without adverse effect. And lastly, when we add insulin and basal insulin, please continue the sitagliptin as the continuation of sitagliptin in addition to the basal insulin results in more controlling the glycemic effect of the reduction of A1C. Most of the patients reach the goal of A1C less than 7 appropriately with less side effect and less hypoglycemia.